talking about Sebelius and the morning after.
And the morning after.
The morning after.
I'm glad you're here for the morning after.
So, I'm here for the morning of. The afternoon
How many
of.
of you know about this? I mean, you must all have heard this. You certainly know who Kathleen Sebelius is, right? She's the secretary of HHS, Human and Health Services. And the morning after was the morning after pill, right? Known as Plan B one step today. So what I'd like to do is just introduce the players. And that first one is, whoops.
Make it a little darker.
Wait a minute.
There we go. Kathleen Sebelius, appointed by Obama, born in Cincinnati. Cincinnati's home of Skyline Chili and Grater's Ice Cream. I grew up in Cincinnati. Love the stuff. And she was a daughter of John Gilligan, who was Democratic governor of Ohio, and then in '74 moved and got married. Became governor for 2 terms in 2002. And then when Obama came into office, there was some question how she wanted to sort of play a role within his administration, and she ended up being secretary. Okay? So that's lots of experience in terms of politics. Here's Margaret Hamburg, born in Chicago in '55, graduate of Harvard College and the medical school, became commissioner of the FDA. And you'll notice at the end there, she says she wants to make the sort of decisions that are involved in policy more transparent. And the reason is that under the Bush administration, there seemed to be a lot of backroom deals, that people weren't being transparent about the decisions that they were making or how they were coming up with those decisions. So there was a new era. And Sebelius actually went to the FDA and met with Hamburg, and everyone was happy. Okay, it seemed like it was going to be a new era, especially respecting the integrity of science. Obama at this time came out and said, look, we're not going to be like the Bush administration. We're actually going to allow the science to inform our policy, whether it's inconvenient or not. Okay, those are Obama's words. Well, this is the third player. It's the emergency contraceptive, Plan B one step. It was initially introduced in 1999, and it wasn't one step, it was 2 steps. It was 0.75 milligrams of a progesterone compound that you had to take 12 hours apart. Okay, and it's good to take it within the first 72 hours. Within the first 24 hours, it's sort of 80% effective, and as you go on down from there, it drops down precipitously, okay, by the 3rd day. So the issue is that it was only by prescription. Well, that's not good. You got to go see your physician, right? You got to get this prescription, so you're talking maybe a couple days. So you're kind of sliding down the efficacy scale of this. So, and this is where the debacle occurred originally with the FDA, is that the Bush administration sort of dragged its feet until the courts intervened, so that in 2006, finally, you could get Plan B, OTC, or over-the-counter. And that was for women 18 years and above. 17 and below, you still had to have a prescription. Okay? So, Obama comes into power again in 2009. That age is reduced down to 17 years. Okay, so you can get it without prescription if you're 17 years or older. And the company was told, look, we'll make it OTC, but you have to do some studies to show, and these are the 2 studies, comprehension. That is, you can actually read the label. Take this pill is basically what it says. Okay? Can you comprehend that? Can you read that? And the second is the actual use study, is that can you use it? Okay? In other words, it's Plan B. If Plan A fails, can you read this label and take this pill, okay, appropriately? And what you'll notice is very important. These are the females that they took a look at the age 12 to 17 for the comprehension study, which was actually published. But the actual use study from 13 to 17, that stuff has never been published, okay, which is somewhat problematic. Okay, so they did their studies. 2011, it was coming down to the final week that the FDA was going to make its decision. It had made its decision, and then on December 11th, not such happy times anymore between Sebelius and Obama, as we saw in the first slide. Sebelius overrules, okay, the FDA. And what she said, several things that she said, one of them is that the data that was submitted just wasn't quite adequate in order to make Plan B OTC. Okay? And what she said is that it didn't include 11 years old. If you look at the age of reproductive females, it's from about 11 on up, okay, to menopause. But in those 11 years old, only about 10% of 11-year-olds, okay, can actually reproduce. It's hard to find 11-year-olds. It's not really a fair criticism of this. Remember, they only have a pool of about 300 people, and they sort of did this at the mall and stuff like that. They think teenage females go. The other thing that she said is that younger teenagers are simply developmentally different from 17, 18-year-olds and may not be able to appropriately comprehend and use Plan B as Plan B as opposed to Plan A. Okay, so those are the two criticisms that she sort of makes to justify her overruling. Well, Humbert also puts out a statement saying that the Center for Drug Evaluation and Research was just about ready to give the imprimatur to have this OTC. But along comes Sebelius on December 7th, says, I'm sorry, we're going to overrule you on this. And she obviously was very unhappy. Okay? She was not the only one that was unhappy. This made headline news, both within the press as well as on TV. And here's from the New York Times, first time ever, and that's kind of questionable, the Secretary for HHS publicly overruled the FDA, refusing to allow emergency contraceptives sold over the counter. The decision avoided what could have been a bruising political battle over parental control and conception during a presidential election year. So what do you hear behind here? Their values, aren't there? Their values that are informing this decision, whether they're political or social or cultural or religious, or they might be. It was based upon values, and that's verboten, as you all know. Right? Values cannot, because what? It leads to distortion of the data and misinterpreting. Okay? Making claims that the data actually may not be safe. Well, it just wasn't the public arena. Nature came out later that month, Christmas time, 24th-ish, 24th of December, and the morning after. And oh, do they hammer him? Okay, remember 2009, Obama says, integrity's back in for science. We're going to make our decisions, our policy decisions, based upon the best data, okay, that's available. So we're going to have integrity here. And so Nature comes out and just really blasts over this as allowing these political values to have play in terms of policy formation, or at least projecting. Now I want you to remember this Nature article, okay? Because I'm going to show you another quote from an issue that just came out last month. Okay, but let's continue on. with a bashing. Okay, New England Journal of Medicine by Wood. And Wood had written back in 2006 when there was this debacle with Bush and the FDA. And the commissioner of the FDA at that time, same words, that the data wasn't good enough, if you sort of remember. I mean, it's almost verbatim what Sebelius said and the previous commissioner had said. And Wood had written another editorial piece, which he had entitled Another Sad Day for Women. Okay, so in the New England Journal of Medicine, obviously says Plan B is more dangerous to politicians than to adolescent girls. And here in contraception, Kelly Cleland then makes this charge, and it's sort of at the end here, that this is a pseudoscientific emphasis on 11-year-olds, that somehow the data was incomplete. Again, it's not so much pseudoscientific as it's just different values, I think, that were informing the decision that was made. Well, just to make sure that they just weren't bashed, there were some people that actually applauded the decision that Sebelius had made, and I'm not sure if you all surfed the web. So it's Hot Air, one of the sites, and this is Tina Court, who says, I cheer this decision because she's the same mind of John Paul II. And basically, a lot of conservatives see Plan B as an abortion pill. And it's not clear. Okay, there's three possible mechanisms here. One, it prevents ovulation. Second, it prevents fertilization. And the third, this is where they come up with the idea of being an abortion pill, that is, it changes the uterine lining so that you can't have implantation of fertilized ovum. And they see that as abortion. Okay? So, the reaction to this decision was clearly right down conservative and liberal lines. Liberals were appalled at it because one of its most important values is integrity of the data, and using that in order to inform your policy. For the conservatives, it's minors having access to emergency contraception, okay, to the Plan B. So those are the values, I think, that are sort of informing the reaction. Well, we've talked a little bit about what values are, and I'm with everyone else. There's really no one good sort of definition to value. But when in doubt, always go to the Oxford English Dictionary. I was taught as an undergraduate. And there, in sort of the second section, definition number 6, part D. This seems to be a good definition. Principles or moral standards held by a person or social group, generally accepted or personally held judgment of what is valuable or important. Seems fairly good, don't you think? Seems to capture what we mean by a value, and we could talk about that more. But it smacks a lot of what? Of sort of morality and ethics. But philosophers also going to talk about, and we've heard this, that you mentioned the epistemic values. We'll talk about epistemic and non-epistemic values. Epistemic values, of course, this comes in through Kuhn, who talked about objective and subjective values in one of his essays. And these are going to be the cognitive values that promote truth-like statements. Okay, so simplicity can operate as a value. F equals MA is a very simple statement, and some people may accept that simply because cognitively it appeals to them. It can also operate subjectively, Kuhn says. So it can be non-epistemic. But most philosophers are going to talk about social values or cultural values or religious values being the non-epistemic values to determine whether scientific knowledge is useful or relevant in terms of utility, okay, or moral. And the third sort of approach to values that I'd like to take is direct and indirect. That is, for epistemic values play a direct role in accepting scientific theories. This is going to be important as we see, as we sort of analyze this case study, and non-epistemic values play an indirect role. That is, they are sort of encoded in the background. This is part of the problem, is that they're encoded in the background and they're never really brought to the table in order to discuss whether or not what values are playing here. Remember nature? Right? Poor Obama. Integrity of science was squelched by Sebelius' decision. This quote, although political science, the practice of science cannot, nor should it be, entirely apolitical. Although political and religious ideology has no place in deciding scientific questions, that is, this epistemic values, the practice of science is inherently political in terms of the non-epistemic values, right? In the sense that science can never come before politics. Scientists everywhere enter into a social contract, and values are going to be important in that. They give a trivial example about being paymasters. Much, if not most, scientific research has social and political implications. And what greater example we have than these emergency contraceptions? Even though you have the good science, the question is then, how then do you make policy? How do you go about doing that? And it's important. Social values are critical for formulating good policy. And this study was done on home birth debate that was just recently published. What they claim is if you, looking at this debate, if the people that are involved in the discussion don't discuss their values, this could be bad policy. Okay? And the home health debate is whether or not you have children in the hospital or at home. Okay? So if you're not debating the values, whether or not it's risk is really what's important, so you want to have birth in the hospital, or you want to have the convenience of having it at home, so you have it at home. These are important values that can have an impact on how you conduct your studies, how you interpret the data, and then how you make policy. Okay, conclusions. I'm doing all right, in terms of time?
Yeah, right now you're fine.
Okay, role of values in science and government policy. Obviously, epistemic values are going to be important and should be protected in terms of coming up with good data, interpretation of that data. But also, non-epistemic values must play a role in establishing government policy, obviously based upon valid scientific evidence. Both have got to be hand in hand in terms of coming up with good policy, because if you don't bring those values to the table, we could end up having policies that are not good. Well, what does the morning after pill tell us? I think there are several things that I've sort of come away with from looking at this case study. I think, first of all, Teva, or the drug manufacturer, has to give us all the details. I think as a public, if we're going to be informed, we need to know if the actual use studies, how they were done. There are lots of problems, with the comprehension study. There are lots of problems there. Okay, I mean that, and everyone seems to think that that is solid scientific evidence. It's not. One study, done by whom? By the company. And it's well known that when companies do studies on their own drugs, guess what? They always find efficacy. It's well established. Okay. So you have this conflict of interest problem. FDA's got lots of money. These can't be that expensive to do, right? Why doesn't the FDA do these studies? The other is that Obama should include the social values. I think he should put those out there. And that leads to this issue of democratization of values. Whose values are we going to use? How are we going to establish them? It would seem that we elect our officials, and they represent those values, but somehow it just never quite operates that way. So is this a place for the social sciences to come in and do the necessary work in order to establish what are those values? What do people value? So that this can then inform policy formation. Okay. That's it. Thank you very much.
So do you want to call on folks or do you want me to,
Oh,
for answering questions?
you are the
All right.
chairman.
I will do it.
So I'm trying to understand what the role is being played here by the 11-year-old is. So if there was was the concern about the 11-year-old not understanding, was that the sort of driving force behind the rejection?
Yeah.
So is there any reason why they couldn't have said everybody except for 11-year-olds?
Could have,
Because that would seem to be, it would be more consistent if, it would be more,
consistent
a
with the
more,
data.
a more clear expression of the value of worrying about the 11-year-olds.
Mhm.
If it was expression of some other value that I'm not understanding, then it seems like it might be different. And so I'm
Right.
wondering if the 11-year-olds are actually the issue.
Well, no.
Yeah.
I mean, obviously, they're not the issue. It's the issue of values, and of course, in this case, it's an election year, so,
So it just doesn't.
yeah. But, it sort of transcends that in the sense that, we want to formulate good policy that's good for society. So I think we have to have our pulse on sort of what that society wants to be. What values does it want to have in order to have a good or a flourishing society? What does that mean? And I think oftentimes we just, as Obama did here and Bush later, had just it sort of suppressed the values. And then as Kelly had written in her editorial piece, had hidden behind this sort of pseudoscientific critique that 11-year-olds. That's a misuse of values in terms of criticizing the data. Yes.
This brings up a conflict. You are separating, values into neat little packages. In teaching public policy for 30 years with a problem-solving model, here's what I discovered. Many of us in science may come up with some, astounding discovery, and then say at the end of a paper or session, oh, this has implications for public policy. And not know how to translate it and feel that political figures are nasty and we're the good guys. How do we bridge that? Public policy is designed to bridge these different sets of values.
And if I may problematize that question a little bit more, because I think this is a really important question. Is it the case that really publishing this information and making the scientific information and the scientific case for making this drug over the counter for 17-year-olds, is that really going to be persuasive? Is it the case that people like the blogger that you mentioned are going to look at that information and go, oh, okay, well, all right, I guess we should have it be over the counter if they already think that a drug like that is an abortive fashion?
No, I think it's important that when you come to policy formation, scientists do kind of wipe their hands, with this ending sentence, and then kind of walk away and say, well, it's not my problem now. But I think it is.
It is.
Their problem. And, how do we set up? What type of structure are we going to have that's going to allow us to sort of set robust policies that really reflect the values of the society as based upon good science? And I don't know the answer to that. I'm not policy formation, but I think we need to, have these kind of debates, but not so misinformed. I mean, if you look at a lot of the statements that are made by people, they've got their sort of values and facts at times wrong, or at least they don't really reflect, I think, adequately what needs to be reflected in terms of forming good policy. So I think we need to have that type. What type of mechanisms can we set up that will allow for discussion and get over things like, you know, is this an abortion pill? I mean, you gotta get over that one. Okay.
Well,
Question
this
there.
is-
Because
but this is
there-
an expression
no,
of
no,
a
I'm
value.
not talking to
It's
you
an
personally.
expression of a value.
I didn't mean you personally.
No, I
I'm
know,
not-
well, I know that, I don't think I know that. But this is an expression of a value. And that's, but this is why this becomes very problematic, because I don't think it's the case actually that more information is necessarily going to persuade people to accept the conclusion that scientists have drawn from the information that they've gathered. And so it makes the policy process more complex, because when you have a debate, it does become messy like this. It's messy like this because people are expressing values that we don't necessarily want to realize are legitimate.
Yeah,
But
and that you
democratically, we
can't
have to.
empirically determine.
Right.
It goes back to Collingwood wrote it's called Essay on Metaphysics in the 1940s. And in there, he makes a distinction between what he calls absolute and relative presuppositions. Okay, and the same thing can be made about values at times. There's some values that lend themselves, well, we can show that this is good in terms of the outcomes. There are others, and these are the absolute values, they're absolute presuppositions. People just hold, and we don't know why. It might be psychology, who knows what's involved with this, and try to persuade people to change. You know, they have to change their skin, you know, before they're going to make a change in values, right?
So there's like the really cynical reading of what happened, which is the you know, Obama wants to get reelected reading, but and you know, a lot of people in this room would probably be okay with that, and might be okay with this as a political tactic. But what if Sebelius had instead said something like, well, you know, there's a lot of people in this country who would be appalled if I didn't override the FDA's ruling, and so I'm going to do it not because of this
Pseudoscientific
bullshit
thing.
about the 11-year-olds, yeah, but I'm just going to do it because I don't want to create this outrage, and you know that I might not personally agree with this, but I think it's like better for the country or something like that.
See,
I
Obama
mean,
comes
do you think?
Obama comes close to saying.
Does
He has the speech where he says, "I'm backing up Kathleen here because we don't want this to be available to 10 and 11-year-olds." He says 10 and 11-year-olds next to the bubblegum machine. Okay, that's what he says. So
It's like creating propaganda for the other side.
Yeah,
I mean,
right.
it's just like,
Oh, believe me, they jumped all over him for that statement. But
Yeah.
that's about as close as you go. Yeah, the question is, why doesn't she do that?
yeah.
Why can't we do that?
I mean, what do you
So
think
the
about
opens-
that? What if?
I don't know.
I mean, if we're yeah.
I mean, it's.
Okay.
I mean, we've deceived ourselves, and we're so dysfunctional when it comes to values. You know, we just can't seem to get them out on the table and have a. You know, it's the whole issue of. I mean, is it a larger issue? You know, I mean, radio talk shows. I mean, they've become. I was listening on NPR the other day, and they've become so polarized that you have these two disparate fractions who simply can't talk to each other anymore in a civil way. Not like Brooks and Shields, right, on Friday night, where you have civil, right? They won some award from, what was it, Vanderbilt or Emory for being able to civilly dispute their differences. We're just so afraid. Why?
I just want to follow up quickly on David's point, because I think part of it is it values, or is it that we also, I mean, in addition to that, what we have publicly and maybe academically as well, a misconstrued sense of what the policy process is, right? And so, to some extent, your comment brings up this idea that we should keep up the ruse that evidence is what people use to make decisions in policy making, you know, and it's not to say that evidence isn't used, but that it's just much more messier than it is about rhetoric, it is about persuasion, it is about mobilizing other kinds of resources, right? So is it actually, I mean, sometimes I wonder if we're looking deeper into the process, so thinking about values rather than it's just actually the way politics functions.
All right. Well, thank you. again very much. Danielle, you have a PowerPoint also? Huh? So you have to switch it over?
It's in there
Oh, it's in there already. So I think I saw an article in the New York Times recently that said that the only science that people believe these days is science that agrees with their pre-existing opinions about how the world is. So if the science doesn't agree with it, whether it's evolution or, you know, you name it, then they don't believe it. So,
Dan Zerwitz has called this an excess of objectivity.
that's what?
An excess of objectivity.
An excess of objectivity? Or a, why is it called excessive objectivity? It seems like it's repressed objectivity. Okay, so I don't even have to tell you that Danielle is from the Department of Bioethics at the Cleveland Clinic. If you can read her slides, and you probably can, or you wouldn't be here, you can tell yourself.
Okay, so I'm going to talk about something a lot less controversial and possibly therefore less interesting. Okay, so I'm going to start off with what I think a lot of people in research ethics take as a very basic principle of research ethics, which is that human subjects research is ethical only if it holds out the prospect for generalizable and socially valuable knowledge. So you can see here from the Federal Common Rule, research is a systematic investigation, including research development, testing, and evaluation, designed to develop or contribute to generalizable knowledge. And again, from Steve Joffe, the goal of biomedical research, promoting socially valuable knowledge about health, disease, and treatment, is ethically central. And I should say at the beginning that I'm focused on human subjects research specifically. So the validity component of this principle speaks to the way in which research ought to be designed and conducted in order to ensure that the results are in fact generalizable and unbiased. Scientifically invalid research is unethical in that it exposes research subjects to risks without possible benefit. And there's been a significant amount of debate and discussion around filling out the requirement for valid research and exactly what that entails. So what are the best and most effective methods to ensure that research results are generalizable? But there's been a corresponding lack of discussion in the clinical research ethics literature devoted to filling out the value component of this most basic ethical principle governing health research. And this is from Zeke Emanuel. To be ethical, clinical research must be valuable because researchers should not expose human beings to potential harms without some possible social or scientific benefit. Given the importance of this ethical dictum, as well as the scarcity of resources available for medical research, we ought to have a better understanding of how to assess this value and how it applies to different research programs in medicine. Specifically, if we're going to allocate public health research resources in a responsible manner, we need a framework that will help us evaluate a priori research programs so we can decide where to put our resources. Since there is not a generally accepted paradigm for the assessment of research outputs, I sought insight into this from pharmaceutical valuation schemes. Obviously, these schemes are not developed for the purpose of assigning this kind of value to pharmaceutical products. Really what they're interested in doing is assigning an economic value post-production, right? But I think that they can give us insight into this question, and specifically in two ways. So on the one hand, we can identify some of the important aspects of a research program that are brought out by pharmaceutical valuation schemes. And on the other hand, we can also look at these schemes and see where there are gaps in the value assessments that they provide. And we can use that to inform what our conception of socially valuable knowledge should consist of for evaluating research projects. So, with this goal in mind, I looked at pharmaceutical valuation schemes from a number of different places. I looked at reimbursement schemes directed at both private insurers and public health systems. I also looked at a nonprofit organization's proposed framework for incentivizing health research into diseases which disproportionately affect the global poor. It's called the Health Impact Fund. Probably a lot of people are familiar with it. And also a more conceptual analysis, which was looking for a balance between costly investments into the treatment and research into rare diseases versus lower cost, more proven therapies for prevalent conditions. And despite the fact that all of these schemes are coming from very different motivations, they actually ended up at remarkably similar places. So in each case, the social value of a new therapeutic agent or pharmaceutical was indexed to two contributing factors. The incremental benefits to patients over a baseline, which is established by either no treatment or existing treatment options, and the disease prevalence or the number of individuals expected to benefit from a given therapy. So Patricia Danzin, who's an economist, she recommends that payers for medical services set cost-effectiveness thresholds for reimbursement based on what she calls health gain, which is a concept filled out by basic quality assessments and an analysis of the product's differential effectiveness as compared with alternative treatment options over how many people, right? Similarly, policymakers in the UK recently proposed relying on quality of life measurements to determine the incremental cost effectiveness of new drugs over off-patent or older, less expensive options, and again, looking at prevalence numbers. The Health Impact Fund, which, if you guys are familiar with it, it's about funding research into neglected diseases, recommends using health impact measurements, which look at average quality improvement over a baseline treatment multiplied by the number of people who can be helped. And you see the same thing in an article about the rule of rescue and to what extent we should inform research allocation decisions on the basis of this possibly questionable moral motivation. So I'm going to talk about this model as the linear model of value, and basically I'm just talking about this quality assessment and disease prevalence, these two components is making up that linear model, and it should be pretty obvious why I'm going to call it that, or if it's not now, it will soon be. So both aspects of this model are definitely important to the evaluation of research enterprises, but they really only speak to one aspect of value, and that's the magnitude of the value. So they address individual magnitude by looking at quality of life improvements, and they also look at the population-wide magnitude. So how many people can we help with this product? But what they don't do, or what the linear model doesn't do, is it fails to distinguish between different types of value. And the result is that this model is unable to account for valuable research outputs which don't lead directly to new therapies or new treatments. So there's a causality here that the linear model assumes, which isn't present in all of our health research. And the other thing they don't do, which is important for assessing research a priori, is they don't speak to the likelihood of producing value, right? These are schemes that are focused on evaluating products post-production, post-research. So they can't, this kind of scheme is lacking here in its ability to inform our research or our resource allocation decisions. Okay, so given the large proportion of early phase research, which is publicly funded, any framework for the assessment of socially valuable knowledge in health research should be able to explain the value of important findings which do not lead directly to the development or approval of new treatments. The schemes I looked at are able to account for the magnitude of the value arising out of successful phase 3 trials, right, late phase effectiveness trials, but they don't seem to address earlier phase research outputs really at all. We can imagine a way you might alter the linear model and thereby incorporate early phase research by simply adjusting valuations along temporal lines. And this is a suggestion I saw in an article in IRB magazine. There's some problems here, though. So the idea is that we might compare the linear value of a phase 3 effectiveness trial to a phase 1 study of safety and toxicity of the same product, right? And we could say, well, look, the phase 3 trial is more directly causally linked to this product and the good that it does. And so we can weight that value more heavily than the value of the phase 1 trial. And by assessing studies this way, based on the time between the conduct of the research and the development of a successful intervention, we could alter the linear model in a way that might account for early phase research. I don't think this works. And the reason I don't think this works is that it doesn't fully capture the value of early phase research. So I already said something about this, but the causal connection between early phase research and late phase research outputs is pretty tenuous at best. There's a lot of early phase research that doesn't pan out. There's a lot of early phase research that is not only seeking to assess safety and toxicity, but also perhaps to investigate novel pathways and mechanisms, translational research in genetics, assessing the feasibility of certain delivery models, and also informing other preclinical and early phase research. So there can be any number of reasons to run an early phase study that aren't going to directly causally lead to the production of a new therapeutic agent. And the linear model fails to account for this. Okay. Additionally, Additionally, we're also trying to evaluate these research programs a priori. And so I can look at a phase 3 study and see pretty clearly where it's going, what its endpoint is in terms of a product that's going to be marketed and what that effect is going to what effect it's going to have on the population. But it's really hard to do that with early phase research. Early phase research is very uncertain. That's why the studies are so small. And a lot of it we can't look at a priori and say, here's what the end product is going to be, and here's what it's going to address. Okay, so any kind of a priori assessment tool that we develop for assessing the socially valuable knowledge or the social value of the knowledge associated with research a priori is going to have to be able to address the value of the epistemic gains associated with early phase research, as well as the therapeutic gains that come out of late phase research. Okay. And one other thing that I think the linear model fails to do is that it assigns a minimal social value to research outputs which address orphan diseases. Orphan diseases, the FDA defines these as diseases or conditions affecting fewer than 200,000 people. And if we accept the linear model, it seems like research into these kinds of diseases would be of very little value. But this is counter to policy in the United States, in France, in Europe, in Australia and Japan, which is intentionally set to encourage research into these areas. Now we might accept that the policy is wrong, but intuitively it's really hard to accept that there's no social value in the research into these areas. So take Huntington's disease, for example. It's a rare neurodegenerative disorder. It affects about 30,000 people in the United States and between 7 and 8 out of every 100,000 in most of the developing world. If we think that research into a disease like this is important, then it seems like any account we have for assessing research programs needs to be able to account for the value of this research. So it can't just be about differential effectiveness over how many people, because this won't get any attention at all. So our intuitions about orphan diseases, I think, really bring out this point, which is that social value is importantly contextual. Of course, this is what we've been talking about all day. It does seem, though, that obvious that if we are assessing the value of knowledge from the perspective of the global society, like what Poggi wants to do with this Health Impact Fund, we're going to think that one kind of research or therapy is the most valuable, maybe malaria research, right? On the other hand, if we're assessing the value from the perspective of the national society, we might think something else. And of course, if we're assessing it from the perspective of someone with Huntington's disease, we're going to think, gosh, I really think that research into Huntington's disease is really important. So an adequate conception of the value of research outputs also needs to address the social component of value and consider the question, which social perspective is relevant for making this assessment? And it might be the case that we need to answer this question from many different perspectives and distribute our research resources in a way that reflects this. I don't think social context is the only relevant context. The epistemic and therapeutic contexts of a given research enterprise are also important components. This is addressed to some extent by the linear model, insofar as value is quantified in terms of the incremental health gain over available treatments. But there are a number of dimensions of context which the linear account really is not sufficient to address. So thinking again about Huntington's disease, although there are a number of treatment options for managing the symptoms of the disease, there isn't a cure. We might wish to consider the lack of an existing effective cure for this really invasive and highly morbid condition as part of the therapeutic context from which we evaluate prospective research proposals, right? As opposed to another new drug for heartburn, which is going to help a whole lot of people, but the therapeutic context is, well, gosh, we already have Prilosec and we already have Nexium, and what do we need another one for, okay? And then we also might consider the depth of our understanding of a given disease. So the mechanisms by which the disorder manifests itself, how we might go about addressing it. Huntington's disease is one that we don't have a particularly informed understanding of. So although the pharmaceutical evaluation schemes I started with, the linear model, are designed with the intention of assessing the marginal utility of pharmaceutical products after development, they can also help us in the development of a framework for assessing the value of research a priori by helping to identify where a post hoc analysis fails to account for some of the value inherent in health research. An adequate framework must be capable of reflecting the epistemic value associated with early phase research programs. It also must be capable of explaining the value of research into orphan diseases, and also of taking into account the appropriate epistemic, social, and therapeutic contexts of research, of a given research program, excuse me. I think there's one more requirement, and that is the ability to account for the likelihood of generating a valuable output. So it might be the case that I have a research program that aims at answering a really important question. Maybe if I do this study, there is a chance that I can, I don't know, cure cancer forever or something like that. But it might also be the case that my research study has a very small likelihood of answering that question, right? And on the other hand, it might be the case that my study does not address a particularly valuable question in terms of the other components, but that I've got a great research design, and so I'm certainly going to answer my question. Any assessment that we give of a research endeavor for the purposes of allocating resources needs to be able to balance the value of the expected outcomes against the likelihood of achieving the outcomes at which it's aimed. So how do we do this? While uncertainty about outcomes is inherent in clinical research, there are several characteristics of a study which can be used as surrogates when assessing the likelihood of the production of knowledge. So first, we can look at the strength of the existing evidence upon which a study is based. For early phase research, this is primarily preclinical and bench data, but it might also comprise the results of other early phase studies which have already been conducted. For later phase research, we can look at other late phase research as well as pilot studies and phase 1 and 2 trial data. And these can give us a pretty good indication of a study's likely success or failure. Similarly, we can look at research design elements like appropriate inclusion and exclusion criteria, adequate sample size, and suitable allocation methods. And these can all speak to the likelihood of producing valuable knowledge in late phase research. Design elements in early phase studies can also help to ensure that even research with disconfirmatory or negative results provide epistemic gains which can contribute to future endeavors. So by putting a little bit more resources into our early phase research, we can actually make the epistemic gains much more valuable. And this again, I think, highlights the importance of a framework which can recognize these kinds of epistemic gains as well as direct therapeutic benefits. So, I don't know how I'm doing on time. I'm probably talking really fast. So with all of this in mind, I wanted to sketch at least the beginnings of a framework, and really this is just sort of summing it up. This is pretty much in its infancy. But the framework that I'm suggesting is comprised of these 3 dimensions. Looking at the context of the value we're trying to generate, looking at the type of the value that we're trying to generate, and looking at the likelihood of producing value. So we need to identify, prior to the assessment of a research program, the relevant contextual features. From what population are we assessing value, right? This is also the epistemic context. What knowledge or understanding do we already have regarding a particular disease or condition or mechanism or compound or biologic process? And also the therapeutic context. How many people and what kind of quality of life? So it's that magnitude question from the linear model. What is the morbidity associated with the condition? What extent can this knowledge lead to its amelioration and improvements in quality of life? And also how many and how effective are the treatment options which are currently available? But we do also need to be sensitive to the different kinds of value that can come out of health research. So linear value obviously comprises a valuable component here, but there are other kinds of value coming out of health research, and of course I talked about this when I was discussing early phase research. So I borrowed these terms from Jonathan Kimmelman, who's a genetic ethicist, but we might talk about reciprocal value. So knowledge that can inform and motivate further research at the preclinical or bench level. We can talk about iterative value, knowledge which can contribute to the design of further early phase research, maybe by giving new insight into causal mechanisms or by generating new questions, and also collateral value, knowledge which sheds light on other, only loosely related research programs. And of course, finally, research enterprises must be assessed with regard to the likelihood that they will produce valuable knowledge. So this implies not only assessing the context of the research and the type of knowledge it is expected to generate, but also privileging research agendas which are based in sound research principles and analysis plans, You would think this would be a no-brainer, but I sit on a very busy IRB. Not so much. And again, also incorporating design elements that are made to maximize the epistemic gains, especially in early phase research. There are a number of different ways you can incorporate design elements to assure that even if the research is disconfirmatory, we can answer other secondary questions. So just as sort of a brief context of my own, I should say that the question I'm really interested in is how do we fill out this context of value part of this equation. Sadly, I couldn't do that in 20 minutes, so that's it.
So I'm going to ask you the first question, and that is obviously IRBs only play a role in a small subset of the research. And a lot of the research you were talking about, early phase kinds of research, the IRB is not involved in at all. So you can have much of research where people use de-identified tissues is exempt. You're doing human research, but there's no evaluation by the IRB of what you're doing. So how do you see IRBs fitting into these different valuations that you discussed? Do they fit into everywhere, or are they fitting in just on a subsegment of it?
So I think that they fit in certainly to a large extent when we're talking about actual human subjects research, which I wanted to say at the beginning that I think the general principle from which I start is a principle governing human subjects research. But I do think that a lot of what I said generalizes to these other areas where human subjects aren't at risk when we talk about limited resources, right? But IRBs, I think, can play a better role than perhaps what they do now in assessing the value of a research program in a couple of ways. One of the ways I see is in having a better understanding of the background research. You would be amazed at the number of studies that get funded and perhaps even approved that don't really have the kind of grounding that you should have in order to put human subjects at risk. And I think they can also play a larger role in helping investigators who perhaps don't have a strong background in research design to fill out their research design in ways that can lead to better results. And I don't mean more confirmatory results, but I mean results that are more useful to society at large and to the investigator as they move forward in their research career. Does that answer your question?
Yeah. Other questions? Please.
This is a really cool project. I like this a lot. I just wanted to, well, I could ask a sort of ranty question about the linear model, but maybe I'll save that for later. And just sort of suggest some things that you might include in, what was the first box again? The context of value?
Context.
Yeah. So some things that I would want to know at least would be who's doing this research and how are they funded?
Good.
And especially I'm sort of interested in like the phenomenon we had with AIDS in the 80s where sufferers of AIDS and their families got really involved actually in the research process. I don't have a normative answer to that question, who should be doing this research, but it seems like it might be a question worth answering there. And then also questions again about funding, and then also sort of the relationship between all the different agents or the stakeholders involved in here, right? You might think the Gates Foundation is funding this research to come up with some new malaria treatment that can't be used by the villagers in Africa, or that is perceived by them as another form of colonialism. And so whatever benefits of the treatment might have, if it actually works, for reasons of the context, it's basically useless.
Yeah, so I'm actually really glad that that's where you went, because this is a small piece of my larger research agenda, which is primarily addressing research in lower and middle income countries. And
I think that the context part is importantly informed not only by who funds the research, but also who participates in the research. And that's sort of why I want to get at that contextual question. How do we take into account the context in making normative judgments about what we owe to these populations, about access to the therapies that we develop, about how we pay them for being in the trials. So I think this is a big question that I'm trying to answer, and this is like a little piece that's trying to feed that. So I'm kind of glad that's the way you went. I think it gets a little bit more muddy when we start talking about privately funded research, because then, of course, we've got all of the issues that Justin was talking about in his presentation, which it's a whole nother nebula of problems, but yeah.
Just one quick follow-up. I get very nervous when that pronoun "we" creeps in, right? What are we doing to help these people?
Right.
In part because I want to consider the possibility that could these people in their situation be doing this research themselves? And if we are involved for some relevant value of we, it's as auxiliaries or sort of providing a little bit of support rather than we are doing this research to benefit them.
Okay. Just accept that.
Before the next question, can you back up to that slide so we can all look at that interesting slide in the context of the questions? Yeah, thanks.
So I'm interested in your example about Huntington's disease because I've done some research on it too. And so I'm just wondering about this. So there's this intuition that it's important to research Huntington's disease, and you're making the case that parts of that has to do with epistemic context, that we understand so little about it.
Well, I think yes, but I think the bigger one is the therapeutic context, that there's not a cure and that the morbidity is very high. So it's a quality of life issue, certainly.
Yeah, so I'm wondering about that though. I mean, I want to say it's important because I spend so much time thinking about it and things like that, but if I sort of think about the impact of type 2 diabetes versus Huntington's disease, it's not even in the same ballpark. And so I'm sort of getting the impression that maybe, I mean, this is really a thought provoking, I'm getting the impression maybe that one of the reasons why I'm so interested in promoting more Huntington's disease research is something more akin to interest in charity or something like that, or the sort of social revulsion at this idea that people can have no idea what's wrong with them and they're discounted by society, and we call them orphan diseases for a reason, that they've been neglected or something like that, which seems very different than portraying it as a matter of, well, we don't have an adequate therapeutic context. It's something, it seems more affective to me or something like that. This is just my sort of process here.
No, and I think that actually to some extent that's right. So I briefly mentioned a recent paper about the rule of rescue and the question as to whether or not we can really, or we ought to, make our resource allocation decisions based on this sort of gut reaction that we need to help the person that's in front of me, or I need to help this guy that's got Huntington's disease. And I'm not certain where I fall on that debate. I mean, I think there's a lot of good arguments in either way. Just sort of an anecdote about that, I had a really interesting conversation with a guy named Woody Moss, who's a nephrologist, and an OBGYN physician just a couple days ago, and we were talking about how do you balance the person in front of you versus how we make our policy decisions and allocating money. And what I found most sort of striking from the conversation was that the practicing physician in the room was the one who was arguing like head on, I don't care about what effectiveness research shows, I'm going to treat this person the way I know to treat them because it's worked for me, and bugger all to policy and allocation, I don't care. And it was all the ethicists in the room who were saying, oh, but wait a minute, we have to think about this policy implications of this. And it was a very striking sort of break there.
So I think you need to deal more with this issue of the funding, because there's a long space between the funders in the United States at the National Institutes of Health and the scientists who decide what they're going to do and apply for money. It's a very, and the amount of money that's available is really limited.
That's correct.
So somebody has to decide how you're going to decide how much to allocate. That's one thing. And then the other thing is that to bring a drug to market at this point is more than $1 billion enterprise. So who's going to spend the money to bring $1 billion drug to market that's not going to be able to recoup their investment? So that the values, the values structure is really important to think about, but there's a practical context in which it's playing out that really distorts everything.
Yeah, so I do think when you start bringing in private funded research, there's a whole other bag of worms in terms of the cost of research and development, and I do think there's a good argument to be made that it's not as much money goes into R&D as the pharmaceutical companies would like us to accept. But abstracting away from that, we can still look at the research that we're funding and look at the way we're allocating our research dollars and how we assess the value of the research that we're deciding to put into play. So, one of the biggest problems actually is just that the people who are often reviewing the research, whether it's at the grant application stage or at the IRB stage, which, there's two different levels of review there, they don't actually have an adequate enough understanding a lot of times of the science they're looking at to really be able to judge the prospects of a given study. And there are simple things that you see sort of over and over and over again. I can't count how many studies I've seen that have been funded based on wildly, ridiculously optimistic recruitment goals that are just never going to happen. Never going to happen. But we're going to dump a whole bunch of money into this study anyway, and it's going to go for 4 or 5 years, and it's going to flounder, and they're never going to get their sample size. There's these little ways that we can help or that we can fix the way that we're allocating our funds for at least publicly funded research.
It's interesting to me that I really appreciate your framework, and it seems that, if I understand correctly, that this is to look at a particular research program. So what happens when we want to think about the distribution of resources across research programs? Do you see that like future work, or have you thought about how your framework might extend to that? Because I think that raises a whole other host of issues, right?
I think it does, and it's not, until you ask that question, it's not something that I really thought about, the connection between this directly. But I do think that, to some extent, I sort of alluded to this problem when I was talking about the social context and the idea that we might need to look at our broader research agenda from multiple different perspectives and see that if the values are going to be different across those perspectives, we might need to distribute our resources in a way that acknowledges that and accepts that different sections of our society and different segments are going to value different kinds of research outputs. So, the broad answer is there's a lot of things you can say there.
Yeah.
There's some gesturing at it.
How do you priority set, say, diabetes versus Huntington's?
Well,
right?
that's
a
I
great
think
example.
that's.
And that in some ways it seems challenging to think about an absolute way of measuring a research program without accounting for the distribution.
I think that's right. I agree with that.
All right. Well, thank you very much.